I'm Robert Schertzer, Clinical Associate Professor, UBC Ophthalmology and Visual Sciences, and we're talking about glaucoma for August 2nd, 2009, in which I continue my conversation with Stephen Drance, Professor Emeritus at UBC, on normal tension glaucoma. In this episode, we discuss the risk factors in addition to pressure that affect the progression of normal tension glaucoma. Please check the show notes of the podcast for references. Follow me on Twitter, where I am Rob Schertzer, and on my blog at wholelottarob.com, where I cover glaucoma, health, and technology.
Well, now, we were then in a position to see the tremendous variability of the disease, and were able to link the variation with some of the other risk factors in those patients to see whether some of these risk factors were responsible for the variation. And that's where we found that females, untreated females, had a more rapidly steeper curve, more rapid progression of their disease, untreated disease. We found that migraineurs had a more rapid development of the disease than non-migraineurs. That when I say migraineurs, I'm talking about people with a history of migraine. And thirdly, we showed that people who had a disc hemorrhage at the baseline time of the study, when they entered the study, progressed more rapidly than those patients who did not have such a baseline hemorrhage. And those were obviously different groupings of patients. Among the migraineurs, of course, there were a number of people with Raynaud's phenomena, cold hands and feet, and they behaved like the migraineurs. In other words, they progressed more rapidly than people who didn't. But the number of Raynaud's phenomenon was relatively small, and one couldn't really draw any conclusions. But the femaleness and the migraine were certainly separable. In other words, they were both had prognostic implications.
Now, given that with studies you can only really prove what you set out to look for, how did you end up deciding to look for these factors?
Well, those factors were looked ahead of time. In other words, we already knew when we designed the study, at least I knew when we designed the study, and I insisted that smoking and migraine and, of course, disc hemorrhages go without saying, that all of these things were properly annotated by all the contributing physicians, and the record keeping was very good. So we could then go back, and therefore we talked about cold hands and feet and Raynaud's phenomenon, because that was already talked about after Phelps published his original work on migraine. Femaleness was very unexpected. We then... Yes, no, go on.
I was just going to ask, I guess we'll get back to tie this together with how we approach patients today, yes. But if you were going to continue with more of the history.
Well, no, I then... I've talked about the four papers. There were the clinical trial, the scientific study of pressure, the untreated disease, and the risk factors in addition to intraocular pressure that obviously influenced the process.
Right. We should clarify too then, these risk factors then are risk factors for progression as opposed to risk factors for having normal tension glaucoma?
Yes, they are risk factors for progression, and they are not the same as the risk factors for glaucoma. But some of them obviously appear in both groups. We then, when we realized that there were other risk factors that we could find, we then decided that we should go back to the randomized data study and really look whether the subgroupings with those risk factors behave differently in terms of what the pressure did to influence the disease. Now you realize that by this time some of those groups were not necessarily large enough to draw some conclusions, but there were some very clear-cut conclusions which we could reach even from those small groups. Well, the first one was that males, that being a male really showed much less danger, much less effect from pressure reduction in the randomized study. The females, on the other hand, showed a very definite change in their course. The migraineurs also...
So that is, lowering the pressure in females is more likely to keep them from progressing.
That is correct, to
males.
ameliorate their progression. Whereas pressure reduction in males, not really statistically significant. One always has to be very careful when one speaks about such groupings, because this does not mean that all females behaved one way and all males behaved another way. Right. There are obviously traits that we don't recognize in sex distribution that obviously there are some males who didn't do well, and presumably some males also improved if they had major sort of pressure factor. The next thing that was very interesting was that patients who had a family history of glaucoma did not improve with pressure reduction, whereas those who did not showed a very definite effect of pressure reduction. And we showed also that patients who had a cardiovascular disease did not do nearly as well as patients who did not have cardiovascular disease with pressure reduction. Patients who had a family history of stroke did not show the same effect of pressure reduction as patients who did not have such a family history. So now these then are, it was very clear therefore that there is a difference in how pressure reduction affects different subgroupings. And although we wouldn't say that all the groups would satisfy every statistical requirement, they were statistically different, but not necessarily in the sense that one would want for the rest of the study. But I mean, when you talk about maleness and femaleness, the groups were large, and there was just no question that they behave differently.
And also, given that we wouldn't alter our treatment, we would still be attempting to lower the pressure, whether it's female or male.
Yes.
We can't just generalize with...
No. In other words, they were randomized not because of subgrouping. Right. They were randomized in the study, and obviously many of them everybody belonged to some subgroup. Yeah. And so really that was those were the conclusions of the study. And they have some very interesting implications.
Yeah, they sure do. Any pointers then when seeing a patient who has what you're convinced is normal tension glaucoma and how to approach them?
Well, I think that if I were a purist about this, I would say that no patient with normal tension glaucoma should really be started on treatment until they show that they are currently progressing, because 50% of our patients did not progress, and therefore theoretically pressure reduction might not have been terribly beneficial to them.
Right, that's a pretty important point.
That is important.
One point, though, that always comes up when giving recommendations like that has to do with something else that was looked at in the study, and that is, what about when the defect is close to fixation?
Well, there were 4 patients who lost fixation during our total treatment, total study, of whom 3 were in the pressure reduced group and 1 was in the non-pressure reduced group. So you can't draw any conclusion from that,
right.
But certainly I think, in view of the fact that we didn't really show any difference in the behavior of those who threatened fixation from those who didn't, I don't think that should be a factor. But let's be very clear. Clinically, if a person comes with a history that 3 of his sisters were blinded by the disease and both father and mother lost their vision, one doesn't wait. One doesn't have to wait. I think one says, never mind the science, I think this patient should be made as safe as possible.
Right. Didn't the science, if you're going back to the study, say if there's a family history, they were less likely to progress?
No.
Or to respond to treatment?
The patients who had no family history of glaucoma were less likely to progress. B5, where we looked at the subgroups and the effect of pressure reduction on their disease, the patients who had a family history of glaucoma had a better response to pressure reduction than those who didn't.
Okay. So that's consistent with our gut feeling that we would be more inclined to treat.
Quite consistent with it, yes.
It would also make patients feel more comfortable to have something being done.
Yes, yeah. The other thing arising out of this is, well, having said that, really, I would recommend that nobody who is diagnosed as normal tension glaucoma should really be treated until it can be shown that they are currently at having a problem. And that includes disc hemorrhages, and it includes other things, but one needs to be, I think one really shouldn't be attacking people with pressure reduction until they are known to belong to the grouping that is progressing. Right. Remember, really only 5% had a rapid progression, and of course that becomes
it would be obvious when you're following
very clear. I mean,
change.
2 or 3 visits and you can see the thing just being eaten up. Incidentally, this isn't published anywhere, but obviously there were females who were migrainous, who had a disc hemorrhage, and if one sees some of their slopes of deterioration, it is precipitous.
Wow. Now this is something that now would be completely speculative, now that we do pachymetry on patients, measuring their corneal thickness, and we had a patient with a low pressure, and they have extremely thin corneas, more inclined to treat, or still wait for progression?
Well, no, I would not change on that parameter, because I don't think that even if it is known that their pressure is elevated as opposed to being the normal tension glaucoma group, that really doesn't make any difference to the glaucomatous process. If one looks at normal tension glaucoma and glaucoma as separate diseases, one is completely missing the boat. There are patients with glaucoma, which includes both normal tension glaucoma and glaucoma, who have certain groupings of risk factors. And even the normal tension glaucomas, the vast majority of them responded well to pressure, which means that pressure remains an important factor in the majority, even of those whose pressure was never elevated. That really is important, but I don't think I would change necessarily the advice that should wait.
Good. I think we covered a lot of important points, and unless there were any other things you wanted to throw in?
Yes, I think maybe when we do treat somebody with pressure reduction and they continue to lose ground in spite of the fact that the pressure has been reduced, our immediate teaching, and whether it's even teaching or just gut feeling, is to reduce the pressure further.
Right.
Now, I think we need to stop and think and say, maybe this is one of those people who has some of these other risk factors that are probably causing the deterioration, because you can have people who have no pressure, have pressure insensitive disease
right.
from the other things, at both pressure levels,
right.
high pressure, low
and
pressure.
then you're more likely to cause harm by extreme surgeries
Yes,
to get the pressure into
and you
single
should
digits.
at least see whether you can find some of these other ingredients and, treat them before one attacks the process with more of the same. 30% of pressure reduction is not inconsiderable.
Right.
And certainly there are, of course, many surgical patients who have much more than 30% pressure reduction.
I guess one of those other factors that we look at a lot lately is blood pressure dropping.
Oh,
pressure
yes.
dips.
Well, there are a number of other factors. We only know about the things that we looked at.
Right.
Apnea, sleep apnea, and dramatic blood pressure responses, the history of a shock-like
right.
state in the individual. I mean, those are very important markers, but we don't stop to think about those. And I think when pressure reduction has not produced what we want, at least there should be a reflection that this is so. There are many things.
Well, I still do look at all of those, because the new patient consult sheet that I have on my computer is just a copy of your original consult sheet.
Yes.
So all those factors are checked for in all of your
Yes.
patients.
Well, I think that is, but I'm mindful of a lady who was sent to me from Arizona or Colorado, and because she had a failing glaucoma in spite of having had very successful surgery
right.
in terms of pressure reduction. And listening to her history of stress in business and in her family, where she was threatened by her son, it's a litany of major stress. Now, this woman would be vasospastic, likely to be vasospastic all the time, and smoked like a chimney. And to sort of reduce her pressure even further is probably not the answer to the disease in her.
Right.
It's a fascinating field.
That it is.
The disc appearances also can throw some light on mechanisms. The migraineurs, and particularly the women, have characteristically these sector shape disc changes with scotomas close to fixation or mostly superior, and they can of course be recognized very easily by ophthalmoscopy. Similarly, the peripapillary choroidal atrophy and the beta alpha zones of change always indicate that there is cardiovascular disease going on. I mean by that arteriosclerotic cardiovascular disease.
Right, and the beta zone has been shown to be associated with progression.
Yes, exactly. And therefore, when one looks at discs, they tell a big story. And particularly if there is a generalized enlargement of the cup or reduction of the neuroretinal rim all over the place as opposed to in sector shapes, those are people who are practically never seen without a well-elevated intraocular pressure. Pressure is almost certainly a factor. The myopes behave like the people who have the localized changes, and they do have localized changes in their optic nerve. It's often not easy to find, but there.
And it's often not easy to tell when a defect has just been there forever.
Yes.
From their myopia, and when it's actually glaucomatous.
Yes. Yeah, but no, when you look at the disc, it gives you the story when and I'm now not talking about stereoscopy on the slit lamp with very small magnification, but you have a direct ophthalmoscope, or actually even a Goldman lens, contact lens on the slit lamp with good magnification. No, that's mind you, takes time, costs money. Is it effective? Is it efficient? I don't know, but that's certainly what I would like somebody to look at if I was in that situation.
I think that could be a whole other podcast just discussing the discs.
Yeah, no, absolutely. Yes.
So maybe we will save that for another day. And thank you so much for talking tonight.
Great fun.
That's our show for today. In the next episode of Talking About Glaucoma, I will be talking with Cindy Hutnick from University of Western Ontario Ivy Eye Institute on how to properly take central corneal thickness into account when assessing patients with glaucoma. Talking About Glaucoma is a nonprofit podcast that I produce once or twice each month as time permits in AAC format that includes chapter markers and an mp3 format that does not. I am the director of the West Coast Glaucoma Center in Vancouver and clinical associate professor of ophthalmology and visual sciences at the University of British Columbia. Please send comments or suggestions to podcast@iguy.org. That's podcast@iguy.org. And follow me on Twitter, where I am Rob Schertzer. Also, check out my work website at westcoastglaucoma.com and my glaucoma health and technology blog at wholelotofrob.com. Please read the latest debate on healthcare reform, add your comments, and share with others so that all Americans can get the care they need.